back to the idea of resilience and kindness and quiet time to know yourself. I do feel like finding a way, a practice, a place outside or to cultivate that it's a gift that we can give ourselves.
Welcome to the Health Leader Forge. My name is Mark Bonica, and I'm an associate professor in the Department of Health Management and Policy at the University of New Hampshire. Today's guest is Dr. Seoka Salstrom, the founder and director of the Hanover Center for Cognitive Behavioral Therapies in Hanover, New Hampshire. Seoka has a PhD in clinical psychology and specializes in evidence-based behavioral health interventions with a special interest in anxiety and obsessive-compulsive disorders. In this podcast, we discuss how she grew up in a house without electricity, how she found her way to psychology, her rigorous training in clinical psychology, and how she has founded not one, but two successful practices. And finally, what her long-term goals are in building a behavioral health practice in rural New Hampshire. I hope you enjoy listening to Seoka's story, and if you find it valuable, won't you leave us feedback on iTunes, Stitcher, Spotify, or wherever you may be accessing this recording? It helps other people discover us. Thanks for listening. And here is Dr. Seoka Salstrom. Welcome to the podcast, Seoka.
Thank you.
So I'm excited to talk to you today, and I wanted to start a little earlier in your story than I usually start, because you told me a little bit about your growing up in West Virginia, and one of the things that struck me was you said you didn't have electricity when you were quite young. Tell me a little bit about that.
So I did grow up in West Virginia. I grew up in southwestern West Virginia, close to the coal counties. And my parents were back to the landers. In these parts, a lot of people know what that is. In the 70s, my parents were pioneers in a way. They moved to the area because the land was cheap. They were really interested in small family farming, sustainable living, getting off the grid. And they and other people they knew at the time, my dad had a piece of land that he bought from his brother. They cleared it by their own hands, built a little cabin. The cabin was only one room when I was born. And so we did not have electricity, running water, phone, any of those to 21st century amenities or even 20th century amenities. It was really like growing up in the 1800s in a lot of ways. And
so, sorry, I didn't interrupt. But like, how long till you had some of those things?
So I think we got a phone when I was about 5. Okay. And I think that came after multiple times of our cabin almost burning down and needing to call for help. Or it might have actually been near miss snake bites because the copperheads and rattlesnakes that were up on the mountain were poisonous. And if you got bit, you wouldn't be able to get to the hospital in time to make it. So wow. We had some near misses that way. And then I think that was a time when they decided to try to run some phone lines up there. We were very isolated from other people. We were about a mile on either side. We were on a ridge top, and a mile down the hill on either side was the next house. And the roads were only passable by vehicle a couple months out of the year in those early days. So we mostly walked out.
Wow. So grocery shopping, things like that, didn't do.
Yeah, you'd go maybe once, just for longer periods. It was more about going to, there was a sort of shared co-op space where food would be available for other people who were living in this way. And of course, going to the grocery store. But a lot of it was sustainably farmed. We had animals and the garden, but we also did go to the grocery store. We weren't 100% living off the land.
That's amazing.
But we would only go maybe once a week, and then everything would go. Oftentimes, we wouldn't be able to get it home by vehicle, so you'd put it in the big backpack and carry it up the hill.
Wow. So So you were 5 when you got a phone. Did you go
Yeah,
to
maybe around
school
the
as a,
same time for electricity.
okay.
I did go to public school. I started going to Head Start, actually. It was a very impoverished area, so there were no preschools, but there was Head Start. And I went and started that when I was about 4. But in order to get there, it was about an hour and a half bus ride one way on the same bus with the high school kids. So it was all one bus. And
Wow.
the bus stop was about a mile out. And so we got up quite early, 4:30, hike out, and I get on the bus to go to Head Start. And then I did go to public school the entire way through my same school in the
Okay.
little town that was about a half an hour away by
Wow.
car, but by bus it was hour and a half, depending on the conditions.
How did growing up like that influence your thinking as you started to get ready to go to college?
I was very comfortable on my own. I was an only child until I was 10. I spent a lot of time in the woods. There was a lot of hardship, and we did modernize over the years. So by the time I went to college, we were no longer living in the cabin, and we had all the normal modern amenities, and the road was more passable, et cetera. But I had never lived in a big city before. We did live in Lexington, Kentucky for 2 years in the suburbs while my mom was getting her master's degree. But other than that, I had lived in that same place. And so going to college, I was looking at small schools for the most part. I wanted a place where I was a runner. I wanted a place where I could go running in the woods. I was mostly trail runner. And that was also very achievement oriented. So I was looking at places like Duke and places that to me had a prestigious name, but I didn't really know what I wanted other than I wanted to be outside, and I
Yeah.
wanted to be a writer. I was actually
Okay.
an English major and wanted to be a writer, but I chose Guilford College, which is a small liberal arts college, largely because of the woods
Yeah.
at first.
Okay. And so you went to Guilford College. You said you started as an English major, but at some point, obviously, you switched. Well, maybe not obviously, but at some point, you switched to psychology. What was the precipitating moment when you decided, maybe not English, maybe I'm going to switch over to psychology?
I had an opportunity my freshman year in college to do something called a vision quest. There was a woman in Greensboro, North Carolina, who contracted with the college to take college freshmen or sophomores on this. It was sort of she had redesigned it for college students. It's a Native American rites of passage that she had designed in such a way to offer college students a way to get in touch with their story, their life so far, their sense of purpose and clarity and what they wanted to do next, and also build community. And so this was a 6-month process that we engaged in, a group of 8 people. And we, as a group, became very close. I was so fortunate to meet them. And it was during that 6-month preparation process before our actual vision quest up on the mountain where we had what's called council. And council was a time when we would sit together and listen to each other. It wasn't a time for to give people advice or to problem solve their whatever they were talking about. It was a time for just deep listening. And the phrase that was used at the time was holding space. And the relationships that we developed and the what I experienced in those council meetings and with one another when we would call each other on a Sunday night when somebody was going through something hard. I'd not had that before, and it felt unique and sacred. And I had a moment with one of the women who was in my group, maybe halfway through our preparation phase. And I still remember going over to her house and listening and sharing with her, and then walking out to my car and standing there like I'd been hit by a bolt of lightning and just feeling this is what I need to do. this is what I want to do. Just that.
You wanted to listen.
I don't know how else to describe it. Yeah, just that space and listen and be whatever it was that we had kind of created together in that process. I wanted to be a part of that. I wanted to foster that, create that. And I didn't know about psychologists. I didn't know about the field of psychology. I really knew almost nothing at that point. We didn't have psychologists so much in West Virginia. It wasn't something that was in our culture that I grew up in. So I had to explore it from that moment forward.
So once you had that realization that this idea of listening to people was something, or creating a space for people to be heard, how did that then lead you to psych? I mean, in retrospect, it sounds obvious, but I mean, like, how did you, as a person who didn't have a lot of exposure to that, how did you then kind of make that process change?
I don't actually remember too much other than going to the psychology department and meeting with someone and saying, I want to be a psychology major. And yeah, I don't remember the in-between stages. I was just committed from that moment forward. I knew that there was something meaningful that happens when you sit with people when they're in their most vulnerable and scary, dark places. And I felt like I could do that.
So you graduated, and you fairly quickly went into a PhD at the University of Georgia in clinical psychology. What drew you to University of Georgia, and why clinical psychology as opposed to one of the other various possibilities within the broader field of clinical psychology? Within the broader field of psychology, because there's a lot of different branches. Like I mentioned, we've talked about social psychology, or some of the other possible approaches.
I didn't know about a lot of those at the time. I did know that I wanted, whatever I did, at least at that point, I felt clear that I wanted clinical work to be part of what I did long term. And so I guess that my options at that point could have been social work or master's degree in counseling. The people I had in my life at the time, my professors and advisors, and just how I was in my thinking, and also being achievement oriented, I really wanted to go to whatever program offered me the greatest career flexibility long term. I wanted, I had a fairly limited idea of what was available, and I knew that I wanted to go as far as I could go in the degree and in the field, so that I had as many doors open for me in the future as possible. And so that's where I ended up, both at Georgia and also with a PhD in mind. And I was interested in research. And so I wanted both. I wanted the clinical and the research component. And I enjoyed teaching. I thought I would enjoy teaching. I had TA'd before. So all of the facets of clinical psychology in a PhD gave me the opportunity to potentially teach, be an administrator, do clinical work, do research, do all of the above. I wanted those opportunities.
So explain a little bit about what a PhD in clinical psychology is like, because my PhD was in economics. I think it has a different sense to it. I know for you, as a clinician, you have a component of clinical practice built into it. Tell us a little bit about that process of what is it like going through a PhD in clinical psychology?
So at least in our program, we were equal emphasis research and clinical. Some programs are more geared toward research careers, and some more clinically focused careers. Ours was a pretty even split in the training. And so, but the overall picture looks like a 5 to 7 year program. At the time that I went through it, the average was 7 years for a PhD in clinical psychology. Our program was set up a little differently, and in fact, more similar to the way that most programs had been previously designed, which was to go through your first 3 years and then go away somewhere in the country to an internship program and then come back for your fifth year. I think at the time, Georgia was maybe the only program still doing that, but it did have its benefits. They've stopped doing that now. But one of the benefits is that most of us did finish in 5 years. And it was just an insanely intense 5 years, especially because we were competing for top internship programs after 2.5, 3 years of program time compared to 4 years or 3 to 4 years for other folks. But our program had a good reputation around the country, so we did get good internships regardless. We just had to work really hard for those 2 to 3 years before applying. We were started doing clinical work first month in. We had practicum teams, which are teams of an in-house clinical community clinic. And the practicum team means that we had students at every level. So we had first year, second years, third years, and fifth years on the team. And we had every session was videotaped. We had people behind the two-way mirrors. Everybody, of course, all the clients knew it was a student clinic and we were supervised, very closely supervised. We'd watch the videos in our supervision meetings, talk about everything. So the clinical work was really intensively supervised, and that was a big part of what we were doing. And then our research was equal part intensive from the very beginning, working with our major professor in a research project that would become our master's thesis, and then from there, our dissertation. And going back to your question about why Georgia, we did choose, we as in, I guess, folks that were interested in a PhD in clinical psychology, a lot of us would choose that program based on the researcher, the research program that was available, assuming that all things being equal with the quality of the program and the clinical training available.
Yeah, so that's an important thing that I recommend to when people talk to me about going to do a PhD now. That's not something I understood going in. I mean, I hate to admit that in public, but I didn't understand that. There's a lot I would do differently if I had the second chance at it. But so what were you? Yeah, yeah. I guess that's the nature of getting older, right? But like, what were you what specifically were you interested in doing research in then, since you picked it specifically for that?
So I was interested in trauma research. Georgia had several really excellent, well-respected trauma researchers, and my major professor was a researcher in the area of sexual victimization, and but I also did research with veterans and other populations and forms of trauma that people would experience.
And so you did. So this internship idea is different than like what I experienced. So that's a standard part of a clinical psychology program.
It is. It's called a pre-doctoral internship, and it's a 1-year fully clinical position. And we moved away for that year. So we applied all over the country and would move away for that year, and not be engaged in too much clinical research. We'd always have a few projects in the fire, but mostly it was to focus on our clinical training in a very specific area. And then we moved back for our fifth year, but most programs were set up such that you finish your work at the program itself, and then you go do your pre-doctoral internship. You finish your dissertation during that year, you defend your dissertation, and then you have your PhD.
Oh, very interesting. So where was your internship and how did you choose it?
So my internship was in Durham, North Carolina. It was at the Durham VA and Duke Medical. A lot of the internship programs for clinical psychologists at the time, and maybe now as well, this was almost 15, 16 years ago, but were VA medical centers affiliated with academic medical centers. So Palo Alto in California, Boston Consortium, Seattle were some of the ones that I had applied for and interviewed at. And that particular internship was a little closer to Athens, where my husband at the time was living, because he wasn't able to move away from his job. It had everything that I wanted in terms of clinical training, similar to the Seattle VA, where I was really interested in their program as well. And yeah, and also I had some friends in the area, so it was just a good fit for me overall.
So you're at the VA. This is 2004. So what kind of care were you providing? What was the kind of patient you were seeing?
So at that time, you may remember, and listeners may remember, that was around the time that the first OEF veterans were returning from Iraq and Afghanistan. And so I think we saw some of the earliest returnees from that war, but I was also seeing a lot of Vietnam veterans and even a few World War II veterans. And I worked in a couple of different areas of the hospital. I did rotations in PTSD, so I was conducting PTSD interviews. That was very difficult. The interview was a 3 to 4 hour interview asking about their most significant combat traumas. And for most of them, it was the first time they had talked about that level of detail, even for a lot of the Vietnam veterans. And then setting them up for treatment and service connection, which is the term that's used to help them receive medical care and benefit for their service. And I was also doing a sleep disorders rotation, insomnia, military sexual trauma rotation, health psychology, integrated primary care. I can't remember the others, but I was a well-rounded training program.
So it was like a rotational thing. You weren't just doing the PTSD clinic. You were doing you were getting exposed to many different types of patient, types of treatment, so forth.
Mm-hmm. Yeah, different areas of specialty, but really the treatments that I've been fortunate enough to be trained in and provide and are evidence-based treatments, what we might call the CBTs, cognitive behavioral therapies, but more accurately at this point, it's just evidence-based treatments and science-based. And so whatever I was doing were individualized versions of techniques and science-driven strategies that I could teach and use to help them move forward.
So you came back from your internship, did your 5th year, and then what did you do after you graduated from your PhD program?
So then I went to University of Madison, Wisconsin, or University of Wisconsin-Madison, sorry, for a postdoc. A postdoc is a postdoctoral fellowship, a 1-year pre-licensure mandated training program that everyone does if they want to get clinically licensed in a state. And so I went to Wisconsin. I applied again all over the country. I was interested in health psychology at that time. I think that was an area at the VA, and in some of my research, I was developing an interest in the relationship between mental health, or PTSD in particular, and physical health. And so I was interested also in having an opportunity to work in an academic medical center, because I was at that time thinking that would probably be where I would end up. And so I applied to several programs around the country, and Madison was the best fit for me. It's interesting, when I I didn't know anybody in Madison except a family friend who I'd never met before, who grew up in Lincoln County. But when I went to apply there, it was freezing cold. I had never lived in the Midwest. My family was from the Midwest, so I had some far off family. But I went to these other places. They were warmer, and I liked the programs just as much. But I went through some little process of decision making where I tried to take the logistical pros and cons and the practicalities, and I just I weighted all of them by all these different criteria, and Madison came out the lowest. and all the ratings. And then I looked at that sheet and I thought, well, that's too bad because I really want to go to Madison. but
okay.
but I didn't know that until I did that little very practical exercise using my mind to try to decide. But it turns out my heart already knew that I wanted to go to Madison, even though it was not the most practical place to go. It did not meet my criteria.
Okay.
But I did go there.
So a postdoc is a standard part of training, is what you're saying? Because I know, like some fields like economics, you don't necessarily have to do a postdoc, but that would be an expectation if you're in clinical psychology that you would go do a postdoc in preparation for licensure.
It's very much standard. Yeah, I don't know exactly what the legal aspects of it are, but at least at the time and for us, it was standard for people to do a clinical postdoc if they were going to get clinically licensed. And then I even had a colleague at Madison who had just finished a 1 or 2 year postdoc. Oh no, she was going on to do one at Duke in research. So she ended up doing 3 years of postdoctoral fellowship before she moved on to her position. I think she ended up at Stanford. So it wasn't unusual, even maybe a little unusual, but it also was the case that sometimes people would do 1 or 2 years of clinical or 1 year of clinical and then move on to a research postdoc if they wanted that specialized training.
Okay. What does it take to become licensed as a clinical psychologist then?
So it's a certain number of postdoctoral hours, clinical hours that you achieve, and through you have to be supervised, of course, and those supervisors have to meet certain requirements, and then you have to take your boards. So our boards were something we studied for and took our last year and during our postdoc.
Okay.
And you're pretty much there. You have to have graduated, of course. From your
okay.
PhD
you have to have a degree.
Yeah, that has to be all covered before you go to your postdoc.
Okay. So you can't just show up and take the exam. Yeah, I feel like I can do it. All right. So there's some evidence-based activity there, I guess. So you finished your postdoc and moved on to the Rosalind Franklin University of Medicine and Science in Vernon Hills, Illinois. What brought you up to Vernon Hills?
So that was Vernon Hills was essentially a suburb of Chicago, and I lived in Chicago during that time. There was a professor at Rosalind Franklin. Their clinical psychology program, PhD program, was well thought of, and one of my mentors in grad school had gone to that program and had gone to school with a professor there, and he had posted a position in anxiety disorder treatment to be a coordinator of a new clinic that they were building in the department, and so I applied for that position. I really enjoyed in my time in graduate school treating anxiety disorders, OCD in particular. My time at the hospital was wonderful. I learned so much. It was really intensive, but I did at that time decide that I did not want to work in an academic medical center, and I did not want to continue to pursue health psychology. So okay. It wasn't because of a bad experience so much as just I felt that it wasn't the right next course for me. So then again, and it's not unusual for training programs like ours, we were applying all over the country for jobs that would be a good fit for our background and interests. So I again applied all over the country after my postdoc. And but when I saw that particular posting with that particular professor, and I had the connection with him and their program, I was very interested in it and applied and ended up there. So moved to Chicago at that time, 2007.
And so you were with the university only briefly, and moved into private practice. Is that right?
Yeah. So that was a difficult transition because the clinic was really meant to be an anxiety OCD training clinic, and it was sort of a joint effort by the Department of Psychology and their health system, but their health system was not as accustomed to. It was no fault of the department, but the health system, just sort of a related but separate entity, was not accustomed to the work we were doing. And in order to effectively treat anxiety and OCD, especially at the time before a lot of remote options were available, we would go into people's homes, into the community, to do what's called exposure therapy. And at the time, and even now in ways, insurance companies did not often want to pay for that. They didn't understand it. They didn't understand why we had to go to people's homes. It was sort of unconventional in their eyes. And so they kept kind of putting the kibosh on a lot of the treatment plans that we were making. And it got to a point, because this was just a brand new venture that I was involved in, it got to the point about 9 months in that we just decided to pull the plug on it, because it just wasn't going to work in that system. We needed to really...
Mm-hmm. Sorry, was it actually unconventional, or were you guys doing something
not
kind of new?
No, not so much. It wasn't unconventional in for the treatment of anxiety and OCD. We were doing exactly what our research and everything that we had been taught. We were doing what we should have been doing to effectively treat it. It was more that it was definitely different than anything that health system had run across before. They were more of they had medical clinics, not psychology clinics. And for insurance companies, they didn't really know what to do with us. So because I was really I was trained, and a lot of people do think that's a little outside the box of what they're training, unless you're trained in OCD treatments in particular, and a lot of very in anxiety disorders where exposure therapy is a primary modality, then it's not necessarily common to go into people's homes to do their therapy, or to go into the community, or we would go to the top of the Sears Tower to treat fear of heights, or whatever it was. We just went where the fear was. And that was not something that fit nicely into a insurance or bureaucracy. The bureaucracy didn't know what to do with that.
So there wasn't like a code, 30 minutes in an office, talking about one thing or talking about two things. I mean, that's kind of the coding I'm used to looking at. So it just wasn't a neat, they couldn't fit it into a clean coding process that they could then just bill for or pay the bill for.
Especially at the time. I think that's loosened up a little bit now, but especially at the time. It was just in the paperwork, the regulations, that I really did not appreciate them, to my mind, encouraging me to do therapy, treatment plans that were not the most effective. I was interested in doing what was going to work best for people. So so when we closed that, I move into a practice of somebody who had graduated from that same program, had a practice in Chicago, and she welcomed me in, thank goodness. And I kind of had to decide, okay, do I want to stay in Chicago? I had no interest in private practice up until that point. And even after I started working in the private practice, I thought it was going to be a transition period, because I really was more interested in continuing to do some research and being at least affiliated with a university. I wasn't exactly sure, but private practice was definitely not high on the list until I spent some time there.
So what was it like? I guess it worked out okay.
It did. It felt, I mean, to be honest, the work with anxiety disorders and OCD was the most fun to me. And I think there was a period in grad school where I thought, well, this isn't supposed to be so much fun. This is really rewarding. This is just so creative and flexible, and it can't possibly be this fun.
Could you very briefly explain those two disorders? Just kind of a 30-second thumbnail of what is it you're talking when you say anxiety disorder or OCD, obsessive-compulsive. What are those? I mean, I think most of us know those words, but maybe, from your professional vantage point, what does that mean?
But it's a name that we give, just like any diagnosis, a name that we give to a cluster of thoughts, feelings, behaviors that are really impacting someone's life in a negative way. And for OCD in particular, and any form of anxiety that is life interfering, which is really what disorder means, right? It's life interfering. It's a kind of what we might say experiential avoidance. That just means that this internal experience, like a sensation, if it's a panic disorder, or this external thing like heights, is very frightening for me. And so I'm going to try to avoid it at all costs. And so that experience of avoiding that stimuli, internal or external, then makes it just perpetuates it. So we know in our science and understanding of human behavior that the more we avoid something that is part of our, especially daily life, or an internal experience, like let's say for panic, it's racing heart, but that racing heart is just part of the human body. It's just part of the human condition. The more we avoid it, though, the more it intensifies it. And we might start avoiding people, places, experiences, activities that might bring about exposure to that scary thing. And so that's what ends up turning it into a disorder, because it just worsens over time the more you avoid. So the treatment then becomes going toward whatever those avoided experiences are. So going toward it in a very particular way, in a guided way, at the pace, whatever pace the person is willing and able to move at.
So is that,
we can get really, sorry.
Yeah, sorry. Is that both, are you describing kind of the underlying mechanism or pathology? Is that the right way to say that for both anxiety and OCD, or are they different?
Yeah, right. So no, so they differ more in the content. OCD is a little more complicated and doesn't just fall into the category of anxiety disorders anymore, but OCD can take the form of an infinite variety of obsessions and compulsions. A lot of people have the image of cleaning compulsions, or contamination obsessions, fear of getting sick, or there's sort of your standard view of what it looks like, but it can be only internal. So people might only have thought compulsions. There may not be any behavioral compulsions. Just it can look an infinite variety of ways. It can take many different forms. So it's important actually that people understand that the crux is a repetitive, intrusive, unwanted thinking that a lot of people experience that. But when it becomes life interfering and you're doing something to try to get rid of that because it's so unpleasant, and that thing that you're doing to get rid of it or to avoid it is also creating life interference, that's when you might call it OCD.
Okay. And is the treatment in that case, is that also exposure therapy?
It's called exposure and response prevention. Exposure is the exposure to the avoided stimuli.
Okay.
And then response prevention is ways to help people not engage in what we call rituals, which are the compulsions. Ritual is another word for compulsion. And really that just means, again, the thing you do to try to make it go away. This is an unpleasant experience, this thought, this image, this impulse. I don't like it, understandably, and I want it to go away. So I'm going to do this ritual or this compulsion. The problem is it's a short-term relief and long-term perpetuation of suffering.
Oh, okay. So what was it about these illnesses that or conditions that you found particularly rewarding to work with as a clinician?
I can just say that it's very treatable. One thing is that people can become so debilitated by these experiences, and yet the treatments we have available are some of the most effective modalities in all of intervention science. In fact, I think research-wise, exposure therapy is the single most effective intervention we've had in the last 50 years. It's incredibly effective for what we do, especially when it's done. And there's so many nuances to the way to do it well. And we've learned a lot in that regard. But it's very rewarding to see people's lives open up so dramatically when they are willing to trust the process. And we are asking for an incredible amount of trust from them to do, and this is true for all of therapy, really, but we're asking them to go to the scariest, darkest places that their mind is telling them exist, and to do that with us early on in the process. So a lot of relationship building is involved in that, a lot of creativity to try to understand deeply what it is that they are avoiding, not just look at it on the surface. So we got to be really creative together. It's a super collaborative process. And a lot of the things I'm saying are true for all the work that we do. But in this area, to get creative and come up with places to go, and exposures are just creating these opportunities for new learning. So, and we do that together. It was just so fun.
When you say places to go, you aren't speaking metaphorically. You're actually literally.
No, I mean literally. Yeah.
Okay.
Like it might be the bathroom next door to the office because somebody has a contamination anxiety, or it might be I've walked the streets of downtown Chicago with some of the dirt and grime on the street and touched it and had our hands in it. Or I don't even want to share a lot of the things that I've done in the name of helping people with their OCD symptoms. Pretty gross things, but I was all in. I was all in to do what needed to be done.
So the rewarding component is this is a condition that is treatable, curable, or at least improvable.
Very much so. Very much so. And all of anxiety challenges can be very effectively improved with the right care.
So you worked in this private practice for a few years, and then in 2010 you co-founded the Chicago Cognitive Behavioral Treatment Center, which eventually had locations in Chicago, Skokie, and Highland Park. So you had expanded pretty quickly. How did that come about?
I was working at this anxiety treatment practice outside of Chicago, and then I met a woman who was also working there. We became friends and close colleagues, and felt that she had been there for a couple more years than I had. I had only been in Chicago for a couple of years and in the practice for approximately 2 years. But we just had a vision. We had a shared vision for the kind of practice we wanted to build. I think I've always had a bit of a drive to engage in program development, to creatively come up with new program ideas, to want to implement those, and to design my own practice, whether it was a practice or a program, or if I was in the hospital, I would have all these ideas that I would want to implement, but the bureaucracy I felt like was often a impediment to putting these things into place. And so being in that private practice really helped me see I just had to abide by our ethics code and our solid training. I didn't have to ask 10 people in line ahead of me in the bureaucracy whether or not I could implement this idea. And that was very appealing. So when I met Dr. Holly in the practice, we just had a shared vision of some things that we wanted to do differently and what kind of team we wanted to create. We just really wanted to create our dream job for others. And we had a nice model in the practice we had come from, but we had some ideas for some things we wanted to do that was more in line with our values and some of our training. So we took off on our own. And it was in the first year or so that we had those 3 offices. At least 2 of them we had in the first couple of months. And then I think within a year, we had the 3rd one in Lincoln Park.
So 3 offices, how many people involved in the practice?
It was obviously it was a growth. I think in the first year, we only had one or two new clinicians and we would rotate through the different offices. I don't remember exactly the rate of growth, but when I left, we had about 10 or 11 psychologists working in those 3 offices and then a fourth office on the way.
Wow. So what was it like kind of being a founder? You said, you had a vision, you shared that vision with your colleague, but I mean, now you're not just taking care of patients, you're having to build systems, decide, figure out how to bill, all that. What was that like,
Mm-hmm.
making that shift from being kind of employee to entrepreneur?
I think in a lot of ways, a lot of that came naturally to me, to the ideas and the desire to implement and that drive. And it was also not something I had had any training in whatsoever. I had no training in business. I had no training in, I had no training even in the business of psychology or private practice work or any of that. So it was really hard. I say we spent most of our time, I think, just learning from ginormous mistakes, face in the mud constantly. At least I felt that way. It was all it was all trial and error. We had some wonderful mentors that we called up around the country who had practices that we admired and felt like were similar to what we wanted to create, and we consulted with them here and there. But mostly, we just made mistakes and did the best we could. We just learned by doing, and it was hard. It was I tend to take a lot of responsibility for the commitments that I take on. I take I take a lot of responsibility for doing good work with my clients and being a good mentor and creating a place that people want to go to work every day. And so as soon as we had people working with us, I just felt so strongly that it was my responsibility to make sure they had what they needed. Not just, compensation, yes, and benefits and all that, but the clients that they wanted to see, they had the community connections, they had the opportunities to teach at the university if they wanted to do that. So I just stayed really busy trying to create those opportunities for them and make sure that, they had given us their trust by coming on board. And that's the same now with my practice here. And I felt that I owed them that effort. So it was
So
just really a lot of work,
yeah,
an
I bet.
incredible amount of work.
What was it like I assume you still saw patients, or were
I
you
saw a
just,
lot of patients. No, I
okay.
saw a lot of patients during those years.
So you
I
weren't
was
able
I
to
was
just,
working full time clinically and then
uh-huh.
managing and building the practice on top of that, as was my business partner. We were both working full time clinically.
What was the key to success?
Being willing to make mistakes was huge. I was not so willing, but I did make them. I'm much more willing now. I'm much more compassionate with myself and open to making mistakes now. Still not pleasant, but at the time, I do tend to be kind of perfectionistic, and I would give myself a hard time and be pretty hard on myself. So, and it didn't matter, of course. I still was going to make plenty of mistakes. I think the key was I can be risk averse in some areas of my life, but in business, I trusted. I I just trusted a process. I took a lot of risks. We reinvested everything back into the business, as I still do. I just had a sense of where to put my energy. I don't know. Um, a lot of hard work.
Okay. So you were with the business until 2015, when you left that practice to come up this way to Vermont, to the Vermont New Hampshire border. What brought you to the decision to leave a thriving practice in a busy Chicago and associated suburbs to come out to rural Vermont?
So there's several answers to that question. It was a busy, thriving practice. I had I don't know what I might say, a big life there. I was always doing something. I was always with people. I was networking constantly. It was big, and probably bigger than was, well, definitely bigger than was healthy for me in any way. It also, growing up where I did, living in the big city was a little more I adapted, right? I had intended to stay there long term. I had intended to stay there until retirement. When I made the commitment to start the practice there, it was a long-term commitment. I didn't start that just thinking, oh, I'll be out in a couple of years. It was nothing like that. I intended to stay, but the longer I was in it, I think there was a growing sense of this is not the right place for me, and this is a level of intensity that is not healthy for me, largely self-driven. But then at the same time that all of that was ramping up, it was like we would say it was like a train that we just couldn't catch. As soon as it started, there were very few CBT practices in Chicago at that time, and it just took off, and we just felt like we were chasing it the whole time. But I had met some people on the East Coast that my mom introduced me to probably in 2008, 2009, a meditation teacher, some close friends, people that became my close friends, and we would go, I would go visit them in different places along the East Coast. Over time, that started to become more frequent. I think it was in 2013 or so. A few of them moved to Vermont to retire, and also moved to a place that was just a better fit for our philosophy of life, a place that was just, I think, a healthier place to live and grow as a person, and to have a sense of community with one another. And so when they moved here, there was a growing sense in me that I was living two lives when I was in Chicago. And then when they moved here, I had always had this sort of magical idea of what Vermont, New Hampshire was when I was growing up. My dad loved topographical maps, and we always had atlases and maps around the house.
Uh-huh.
And I would sit there with these maps and look at where the mountains and the green were in the different places around the country. And I didn't know what it looked like. We had National Geographic, and I would look at pictures, but in my mind, I would imagine what Vermont and New Hampshire looked like based on the topographical map that I was looking at. And I had this sort of idealistic image in my mind, but I didn't have any reason until these friends of mine decided to move here that I was just going to upstick my life in Chicago, which I was so committed to move. And then when they did, I thought, okay, well, that now I know where I'll retire. And then I started coming to visit more often. And I thought, maybe in 10 years, I'll move there and be with my community of friends. And then I kept coming back to Vermont over and over. One year, I think I came back 6 times. And that feeling of feeling like I was in the wrong place just kept growing. So I made the best plan I could. I just decided at one point that it was time to start the process. I didn't know how long it would take to get myself here, but I just knew it was time to start the process. And I did the best I could to exit with integrity, despite how embedded I was into that practice and that community. It was only 5 years, but man, it was a long 5 years. It was 5 years in the practice.
Sure.
It was very intense. So, and I was really very committed to it.
I mean, that was a thing you created with your colleague. I mean, that's like your baby, right? Like you made this thing from nothing. There was nothing, and then you made something. That'd be hard to leave.
We were working double time the whole time. It was hard to leave. And also, as soon as I made that decision, as maybe you have experienced in your life, the more that inner sense of this isn't right grows, and then you create some alignment in your life, alignment with your heart, your values, that there's a peacefulness that comes with that, no matter how difficult and inconvenient the transition. And
Yeah, I
so
got to
that
say, my decision to
happened.
retire from the Army and come to UNH definitely was absolutely. I had that same feeling. Yeah.
Mhm. Yeah. So it did take me about a year and a half to get here. And then
Okay.
when I got here, I was still consulting back in Chicago. I was still attached in some healthy and unhealthy ways, I think, to my life there. Um, there's the author Elizabeth Gilbert. I remember when I was going through this transition, and I had a lot of people in my life who were like, "What are you doing?" And you're at the top of your game, and where are you moving? But I remember listening to an interview with Elizabeth Gilbert, and she said something like, "I had a wonderful life, but it wasn't my life." And as soon as I heard her say that, I just thought, "My God, that is exactly how I feel. I've built this wonderful life for myself, but I felt so fortunate to have that experience, but it wasn't for me."
Well, that's remarkable.
So then when I got here, it took me 2+ years before I started, 2 years, about a year and a half before I really started working locally. Um, I was still consulting
So your
in
primary
Chicago.
income was still coming. Your primary income was still coming from Chicago, just long distance.
Yeah, for a little while. And I wasn't working as many hours, obviously, and I was also working to build something here. I wasn't quite sure what it was going to be yet, but that takes a lot of time. And I think I also I worked on my house. I just needed some time to decompress after what I had done to myself out there. And in grad school, I mean, I say it was just Chicago, but I was a workaholic. I don't know. So ever since I started grad school, I was overworking. So by the time I got here, that was at least 14, 15 years of overworking.
Okay. So what was your vision coming to Vermont, um, for a you didn't quite have a clear vision of what it was you were going to do? Is that what you were saying? Um, that
I did have a vision. I wasn't quite sure how it would manifest, I guess, in detail. I do. I really enjoy hiking. I enjoy being outside. Outdoor sports. I learned to ski when I moved here. It became it, it it has been a part of me my whole life, but it was not a part of my life so much when I was in Chicago, and I knew that that was not right. I did not live an out of doors life in Chicago, and that is a much better fit for me. So my vision when I moved here was that.
yeah, I have to say, like when you told me the story in our previous conversation about your growing up in West Virginia, and then I was putting that together with Chicago, I'm like, there's some dissonance there.
Yeah, for real. Yes,
Okay.
absolutely.
I mean,
Yeah,
I
some
haven't spent
serious
a lot of
distance.
time in Chicago, but it's not a lot of, that's not an outdoorsy kind of life. Like, I mean, it's a cool city by,
Yeah,
definitely a cool city, but yeah, um,
yeah.
not a lot of woods.
No, no, not a lot of woods. I spent a lot of time on the lake, but not in the water so much, but on just walking along the lake. Um,
Yeah,
but
which
no,
is very
I
cool.
think I was pretty, in some ways, I had gotten pretty far from myself, from the self that knew that I wanted to be in the mountains outdoors. And also that I knew that I wanted to do that more in my career and make that my life, not just a hobby. And I had a sense of what that could look like. But the part that I didn't know yet is how I was going to create that. And still, I'm still working toward that.
Okay. So you did eventually start your own practice here and you created the Hanover Center for Cognitive Behavioral Therapies. When did that come into existence? Kind of like you were just on your own for a period of time. At what point did the Hanover Center uh, become a thing?
Yeah, so I think it was 2017 when I really started seeing clients locally, and when I moved here, I was wanting to create another business venture in outdoor pursuits, less so treatment and therapy focused, but more so growth focused, using the same methodologies. But because what we do is so much about growth and evolution, I don't see it from the biomedical lens. And so to do that outdoors just feels and has been for me an incredibly powerful, transformative process. And I wanted to create opportunities for people in the general population to participate in those kinds of activities, small expeditions, hiking, backpacking. That could look like a number of different things. And so, but I need a lot more training to be able to do that. And so I thought, okay, so I'll move here. I'll see some clients a couple of days a week, try to generate enough income to go to some trainings and learn, really make a pretty big career shift. But as I started working clinically in Hanover, number one, I was not able to, it's pretty expensive to live here, as you know. And it wasn't all about not being able to generate enough income, although that was part of it, just doing a couple of days a week and then trying to train. I also, the need is so great here and in a lot of places, the need is so great. I had a 6-month waiting list within 3 to 4 months, something crazy like that. Maybe not exactly, but it was as soon as I really let people know I was here and I set up shop, I couldn't even keep up, not even close to keep up to the referrals that I was getting. And I know that one of maybe my best, what I can offer is my ability to build, and all the mistakes that I had made in Chicago, and to learn from that and build something new that I felt was even better, for lack of a better word. So it was just gradual. I kept telling everybody I wasn't going to ever start another practice again. It was too hard. It was too much to manage. It's not where I see my life going. But the need was so great, and I felt like that's a skill that I have, and an impact that I can make, a positive impact, I hope, to build a team, a strong team, to do the work in the community and build programs that the community needs. So I met some people just gradually in my communications and introductions to the community. I knew no one in the field of psychology when I moved here. It was all just cold calling and hoping someone would pick up the phone. So now we're a group of maybe 6 or 7. I feel like I should know that exact number, but we have some transitions happening, some new people coming on board, 6 or 7 psychologists, and quite a large administrative staff to support their work and the clients.
So you've largely replicated, just from the outside looking in, it sounds like you've largely replicated what you did in Chicago, but now in Hanover, which, just for folks outside of the area here, Hanover is where Dartmouth Hitchcock, the one academic medical center in the state of New Hampshire. So that's physically where you're located. How different is the practice, is the Hanover Center versus what you did in Chicago?
That's a very good question. Yeah, I have to say, when you say I largely replicated what I did in Chicago, I think that's absolutely true. And there's this part of me that told myself over and over and over, I will not replicate what I did in Chicago. So that's a hard one for me to swallow, even though I know it's true when I hear it. And I've heard it from multiple people. I think on the outside looking in, there are many similarities. I'm different than I've grown. I think I'm different. So the way that I am with the people I work with, I think, I hope I'm even more open, more present, more available. I give more. I had that value then, of course. It's not that I didn't, that my values have dramatically shifted, but the way that how much I give, both in terms of compensation and other things, there are differences in There's a ton more administrative support that I give to the staff here, the clinicians. A lot of that is because I really am trying to create an environment where they can do their absolute best work through trainings that they have a training stipend through, and I'm always encouraging training in certain areas of the field that are growing. And I just try to give them the best possible work environment to live their best life and also to do great work for their clients, with their clients. And the same with the administrative team, that I'm trying to give them a living wage, an opportunity to have their dreams, and to give them a job they want to come to, and to have a team that is as equal as it can be, for there not to be in our, I mean, in the field of medicine, there's often hierarchies
Absolutely.
with support staff and clinical staff, there's hierarchies everywhere. I'm doing the best I can to create a team that is as non-hierarchical as is possible, given the context that we're in and the systems that we exist in. So I'm working really hard to create a foundation for this practice, that it can scale up to the degree that it remains cohesive and just excellent quality care. I don't know that that's fundamentally different than Chicago, but I do feel that I'm doing it in a different way. I've learned a lot. I'm listening and reading a lot about leadership and management. At this point, I have retired from clinical work just recently. So all of my time is spent in management. That was not the case until this year. But so
do you miss
it's
it?
different. Yes, very
it's
much.
It's a relatively recent thing, but yeah, okay.
It is I still have a few clients, but very few. Two, in fact. I do miss. I really enjoy the clinical work that I was doing. It's such a collaborative relationship, and I do miss. I feel like growing with someone, like even the language, clinical work or working with someone, I try to use words like with and together, and it is not me doing something to them or for them. We are working together very much collaboratively to help them evolve and grow. And I evolve and grow in that process just the same. I'm doing my own work. That is very much our stance. We're not treating mental health disorders, even though, yes, technically speaking, if you look through that lens, sure, but that's not the lens we look through. We're all in the same boat. We all suffer. We're all experiencing pain, and we're all doing the work. And I don't say that ever to diminish anything that anyone is going through at all. Everybody has their unique challenges, and some histories provide intensive opportunities for growth. But the stance is not one of trying to remove the power dynamic as much as possible.
That sounds like a great environment to create. Let me ask you a little bit about like the services that your organization offers. Is it specialized for anxiety and OCD, or do you treat a full range of behavioral health issues? Kind of tell us a little bit about the practice.
So yeah, we do work with individuals with a full range of challenges. And when it was just me, because of my specialties, it was really limited to that. Although in a smaller community, I had to become more of a generalist very quickly, and to increase my competence in certain areas. In a big city, you can become more of a specialist and remain that. But in our practice now, with the scope of the providers we have, we specialize in, yes, still anxiety, OCD, very much so, and also working with older adults in a subfield called geropsychology. We have a postdoc in that area. She's wonderful. I have a couple of folks that work with children and adolescents, which is a huge need, as you know. College kids. So we really do have several folks that work with college kids and understand their developmental needs. And depression, of course. We can help people who are experiencing periods of depression. And we also have a neuropsychologist on staff now who's very talented. That was not something that I really had intended or have ever had in our practice. We never had a neuropsychologist working in the practice. So I'm learning a lot in that process of integrating him into the practice. But he's a wonderful addition to the team.
What does he do? What does the field of neuropsychology involve?
So that involves doing assessments for learning disabilities, ADHD, autism spectrum disorders, intellectual testing, academic testing. So all of that.
I know there's a huge need for that.
And for all ages, not just kids, adolescents, and students, but sometimes people in the workplace or just for life reasons will be interested in their learning profile.
Very neat. What's your vision for the future? Where is the practice going? What are the services you hope to add?
My biggest goal in that regard is to just try to understand what our community needs. And right now, we don't have any what's called IOPs. It's an intensive outpatient program. Dartmouth does have a program for substance abuse, but we don't have IOPs for children, adolescents, college kids that are struggling with anxiety, depression, related disorders. We don't have that level of intense programming where people can, for 3, 4, 5 days a week, several hours a day, be engaged in group therapy, individual therapy, their own self-directed practice. And there are some excellent programs in Boston and even Portsmouth and some places, but it's a very difficult thing to refer a family to Boston to do an intensive outpatient program when their child is or adolescent or college student is in need of that, because then they really have to relocate half the family to that place to do this intensive treatment. It's a lot to ask for a family to do that. I have no idea if I will. I have ideas of what those programs could look like. I've worked in conjunction with those programs my entire career, but I've never built one. I don't know 100% for sure if we will build that into our clinic, but we'll move in that direction as long as it's right to move in that direction. We'll figure out if that's something we can build or support someone else to build. But I do think it's a huge community need for more intensive treatment options. I have a real passion for outdoor programming, as you know. So there may be outdoor programming in our future. I'm not exactly sure. I don't mean like a residential wilderness therapy program, nothing that specific, but possibly opportunities for doing the work in an outdoor setting in a programmatic way that would be outpatient and would fall in line with our current, what we currently offer. I also have just an interest in integrated healthcare. It's a long-standing interest of mine. And so I may eventually have a couple of psychiatrists on board or even a physician who's interested in integrated care. Who knows? I have ideas, but no immediate or very specific plans. and it's hard to outline in this context because it will all depend on the people that I'm collaborating with. And I certainly can't build and manage all of those programs. So I would need collaborators, and that will just have to evolve organically.
And I know we've talked about your interest in developing a charitable nonprofit as well. So what is your vision for that?
So for the last year and a half, I've been working with a young woman. Her name is Jordan Hughes. She received a grant to work full time in a nonprofit capacity, and we've been working for a year and a half to develop a charitable fund for to increase mental health access. It is not in existence just yet. It's not fully launched. So the mission is really to try to equalize access to mental health care. There are so many systemic issues around that at every level. And so I feel like even though it is akin to pulling people out of the river as opposed to changing the reasons why they're falling in the first place, we really have very few programs in existence to help people fund mental health care in the Upper Valley, but there are very few programs that we could find anywhere. And it's not an ideal scenario to create a fund to pay. The fund would pay providers to support people's mental health care who couldn't pay for it, either by filling the gap between their insurance coverage and the actual rates, or to pay all of it if they didn't have insurance or their insurance wasn't paying anything. Right now, we have community mental health, which does the best they can with the resources they have, and it falls very short of what the community needs, and only a select group of the population is eligible for community mental health. And then you have the community providers, some of whom take insurance, some of whom don't, but regardless, there's quite a lot of discrepancy in who can access the most appropriate care, both for mental health and for educational services such as neuropsychological testing. There's just a huge gap depending on financial ability, and this fund would try to bridge that gap just at least a little bit, to apply for many grants to pay for their mental health care. So we have a lot of community connections built toward this effort. We have a website in the works. We have an intern starting from your MPH program, actually. And
Yay.
yeah, we're excited about that. She starts next week. It's wonderful. So it's moving forward, and I'm pleased about that. But we don't have a specific date. We'll just keep working on it as we're able to.
Well, I want to close with a couple of questions on more kind of general topics of behavioral health and mental health. So as a mental health professional, what generic advice would you give to people to maintain good mental health? Like, what are the couple of tips that you would say, like, basic things like, you go to, when you're dealing with a physician, hey, eat a healthy diet, get some exercise. What are the kind of mental health similar mental health related pieces of advice you'd say that these are the basic things to do?
Well, you named two of them.
Oh, okay.
So
exercise and diet.
Because
Good. All right.
There is no difference. Sometimes I say whoever came up with the idea of mind body, that was a ridiculous thing to say. We are one organism. And so
that guy Aristotle, God,
I don't know.
somebody way back there. Yeah. Okay.
It makes no sense to me. We are one organism. So yes, I call them the four pillars. Exercise. Finding movement you love, and the word exercise is loaded. I get that, and it can feel contrived. So I just prefer to say movement. Just find movement you love. And being outdoors, we have a lot of data. We don't really need the data, but we have a lot of data. It should be intuitive. We know we feel better when we're outside in the woods, exercising, moving. That's key finding sports that you really enjoy doing. Yes, eating a nutritious diet there's a lot of research on what's called the microbiome, the gut microbiome, and how that impacts our mood. I think that will become, it's a burgeoning area of research. It will become more and more ubiquitous, what we're learning in that regard. And so it's something worth paying attention to for sure.
I've heard of that, and that sounds fascinating. I don't know much of anything about it, but when I heard, I'm like, that is amazing. Yeah.
Yeah. Anyway. It affects, well, because 90% of our neurotransmitters are in our gut. And we often think, well, what's happening in our brain is then moving to our gut. But yes, it's bidirectional, but more so it moves gut to brain, and as opposed to brain to gut. So what we eat is absolutely affecting how we feel, how we are in the world. That and sleep, yes. So really good sleep, hard to come by with lights and technology as it is, but extremely important. The research on these things this is not so controversial, right? I mean, we hear about it all the time because it's true. And then the fourth pillar being mindfulness, or some form of contemplative, quiet, present moment focused practice. That is also key, especially in a technology driven world. It is really important for our mental health. And yes, social connection. So those are 4 pillars, but we could go easily beyond that to social connection, meaningful relationships. It doesn't mean a lot of acquaintances. It means taking risks to build emotionally connected, meaningful relationships, even if it's just a few. And I would say the last thing is our relationship. This kind of goes along with mindfulness, but an extension is our relationship with ourself, that is built on a foundation of compassion and self-kindness. Again, the word compassion is loaded for a lot of people. What does that mean? How do I do that? But we tend to know what the word kindness means. And we know what it means to be kind to a friend. And for most of us, we don't treat ourselves with that same kindness, acceptance, non-judgment. And that is fundamental to our ability to move through the world with more resilience and grace.
That's lovely. So let's leave on. Oh, I have one last question for you. So why should everybody go on a multi-week backpacking trip through the?
Why are you asking me that, Mark?
Because I know you. So for listeners, I know you were just recently on a extended backcountry trip. So what would you? So what does one get out of being in the woods for that long a period of time by yourself, in addition, soloing?
I think that's such an individual thing. I know I don't even know if I know what I got out of it, but it's still unfolding since it was this year. I don't know that everybody should do just that, but back to the idea of resilience and kindness and quiet time to know yourself. I do feel like finding a way, a practice, a place outside, or to cultivate that it's a gift that we can give ourselves to the extent possible. I know everybody is not able to take off for a couple months and do a sabbatical.
I think that's really cool.
Very fortunate to have had the opportunities to do that, largely because of my family, friends, and my team that allowed that. But the essence of that for me was something I'd wanted to do for a long time. It was a challenge. It was taking care of myself in a deep way, and returning full circle to where I came from and how I lived growing up. And in some ways, I felt more like myself out there than I felt in years. I do have a daily meditation practice. I move in the woods and exercise most days. I live well that way. but this was different. This was something I really needed to do to push my limits and challenge myself and face some fears that had been growing. We all have them. So I do hope that whatever that is for people, that if there's an opportunity for some reflection, for some physical challenge, to be in the mountains, to be outside, to be on the water, whatever that is, to take it when that opportunity arises. Because you will learn something.
Right.
You may not like, my lessons were largely because of my failures, as usual. And I'm glad to be alive.
Yeah. Failure tends to be a great teacher.
Uh-huh.
Well, Seoka, thank you so much for your time today. I appreciate your sharing your story, and I learned a lot.
Thank you, Mark. It was nice to talk with you. Appreciate it.
You've been listening to the Health Leader Forge. Please go to our website, healthleaderforge.org, for more information or to leave comments about today's podcast. Look for Health Leader Forge podcasts on iTunes, Stitcher, SoundCloud, and other podcast distribution sites. Thanks for being a part of the Health Leader Forge community, and we'll talk with you again soon.